seminar. We're very pleased to have Dr. Allie Turton here with us to speak on stroke rehabilitation and the corticospinal tract. And we were really pleased to see her speak at Professor Roger Lemon's retirement seminar at UCL, and we picked up on it as a perfect combination of clinical and neuroanatomy, so that's why we asked to see her.
Thank you, Etta. And thank you very much for inviting me. I was somewhat surprised because I went to that retirement seminar thinking I could say thank you to Roger, and I have been out of neurophysiology for quite a long time. I presented things from my PhD, which were a long time ago now. So I'm quite surprised, to be honest, but very pleasantly surprised, so thank you. So I'm, a bit about me, I'm an occupational therapist by background. I work as a lecturer at the University of West of England in Bristol, and I've been looking at stroke rehabilitation research for quite a long time now. So that kind of started out at looking at how people recover their upper limb function with Roger. So I want to talk a bit about that work and then look at more recent work where that thread's led to, and then a little bit about how neurophysiology and animal work in recovery and rehabilitation is influencing stroke rehabilitation now. So every year about 150,000 people have a stroke in the UK, and of course it's a very disabling condition, and those with moderate to severe stroke are particularly disabled, and a lot of that disability comes from loss of the use of an arm. Only about 40% of people with moderate to severe stroke recover useful arm and hand movement, and those people often report other sensations, that their limb might not feel like their own. They report sometimes it feels cold, they report it might feel heavy, and it might be painful. So it's actually a pretty horrible consequence of stroke, and we really need to do something about it. So how does recovery happen? Well, I really like this quote that comes from Paul Bacurita, who's a professor of rehabilitation in the States, and his father had a stroke, and he kind of pioneered, I think, work in plastic changes in the brain, and he explained it like this. If you're driving from here to Milwaukee and the main bridge goes out, first you're paralysed, then you take old secondary roads through farmland, then you use these roads more and you find shorter paths to use to get where you want to go, and you start to get there faster. These secondary pathways are unmasked or exposed and strengthened as they're used. And the unmasking process is generally thought to be one of the principal ways in which the plastic brain reorganises itself. So, thinking about stroke and the brain, now of course stroke might be cortical, it might be subcortical, and so it definitely knocks out roots down to the muscles. So, and this diagram just shows there are a number of different routes that messages can get from the motor cortices down through to the spinal cord and then to the motor neurons. So there are, if one pathway is knocked out, there's the possibility that messages could get down to the muscles through other routes. So here in the green is the corticospinal tract, most of which crosses over at the cerebral peduncle, and then there are other pathways which relay in the brainstem, and these are particularly recognised as serving more proximal axial muscles. There is a part of the, most of the corticospinal tract crosses over in the cerebral peduncle. There is a part, about 20%, 15-20%, which doesn't cross over and is an ipsilateral pathway. And so maybe too there is a possibility that that pathway might have an influence in recovery. You can see also in this how, if you have a stroke which affects the internal capsule where all the fibres are bunched together, how it can have much more devastating consequences than one which is in the cortex. when I did my PhD, transcranial magnetic stimulation was new-ish, and it was used in a very simple way to look at the connectivity in the cortical motor neuronal system, and that's how I used it. And I suspect a lot of you have come across it, but just in case, this is how it works. So you put a electromagnetic coil over the head and position it over where you think the motor cortex is, and the very fast changing magnetic field will excite anything excitable beneath it. So it will excite the cells in the cortex, including those corticomotor neuronal cells that go down the corticospinal tract, and if the volley is sufficient, it will discharge the motor neuron, and you can get a reading and the EMG signal if you apply electrodes to muscles. And I used this technique in a longitudinal study with 21 people with stroke, interested in looking at how the corticospinal tract reorganises along with recovery. These are typical responses from somebody without a stroke, a young man, and you can see that these is a response in deltoid muscle. This is a finger extensor muscle, and this 1DI is the first dorsal interosseous. And you can see how large the response is in the first dorsal interosseous. This is because the distal muscles and representation of the hand are very accessible to the coil. And you can also see how there's a difference in the latency of the response. This is the artifact of the stimulation, and the latency is longer for the hand muscle than it is for the deltoid muscle, and that's just because it's got to get down the arm. Okay. And what we were looking at is the amplitudes and the latencies of the responses to the stimulation, first of the damaged cortex as people got recovery back. So here's some recordings from one person over time. These are recordings done at 7 weeks after stroke, 13 weeks and 24 weeks after stroke in the deltoid, the finger extensor and the first dorsal interosseous. And you can see that as time went on, so responses appeared to the TMS. These numbers here are they're gradings of strength using the MRC scale. So 1 means there's just a flicker of movement. Okay, 3 is able to move and hold a limb segment against gravity, or a finger against gravity in this case, and a 4 is able to hold against gravity and take some resistance, but 5 is normal. So he hasn't got any normal readings here, but you can see he's getting stronger as time goes on in the fingers and in deltoid as well. And what happens, typically the responses are a longer latency to start with, and the latency decreases as the person's able to activate the muscle, and the responses also get larger. But in this person here, all the responses are still much smaller than those on the of the unaffected muscles when the healthy cortex was stimulated. We were interested in the differences between muscles, and so combined the responses and categorised them into 4 different categories. And here you can see what you'd expect normally from somebody without a stroke, and we saw some of these responses in all of the muscles, so that there is EMG, and there is over the top of that a response to the TMS. And then the converse of that, which you probably expect from a severe stroke completely interrupting the corticospinal tract, is that you don't get any EMG, and you don't get any response to the TMS. So those, I suppose, were expected. These ones are the interesting ones down here. So here we've got no EMG, but we've got a little response. This pattern we found in the distal muscles. We found it in the first dorsal interosseous and the finger extensor predominantly. And then in this case, there's no response overlying the EMG, which is present in the muscle. And this was a pattern we saw in proximal muscles. So as a whole, it seemed that as people were recovering the ability to activate the distal muscles, there was always a response with it or just before it to the TMS, indicating some reorganisation within the corticospinal tract. But that wasn't essential for people with who recovered proximal activity. So probably the more indirect routes down were contributing to those, as I said, the kind of those that relay in the brainstem actually responsible, have some influence over proximal muscles. So maybe in those, or possibly it could be the contribution from the ipsilateral, the fibres that don't cross from the healthy cortex that might be driving those muscles. So we wanted to test out the contribution of the intact hemisphere to the activation of the muscles, and what we had a problem really how to do it, because in order to get a response from the people with stroke, we had to use quite a big coil, a little one. They had too high a threshold to get a response. So we used a big coil at the time, and you can see the coil actually crosses over onto the other hemisphere. So supposing this side is my damaged hemisphere and this side is the healthy hemisphere, how do we know when we stimulate that response isn't coming from this part of the coil? My lovely supervisor thought he had a good idea, and he put a aluminium sheet under that side of the coil. Thought that would shield any effect from that part of the coil. But it was an almighty bang, and it was very scary, and it was like a pistol going off. And so clearly we couldn't do that to our participants. So we decided instead that we would limit the intensity to which we stimulated the intact cortex. So supposing the response in resting muscles from the affected side was 50%, our test stimulation over the healthy cortex would not be any more than that. Okay, so imagine the coil's over here. The strongest part of the stimulation is going to come from the centre of the coil and not necessarily that little bit overlapping there. So we thought, actually, if we saw responses from the healthy cortex at a level below equal or below that of the threshold for responses from the other side, we could reasonably assume they were really from that cortex. And we did get some responses. This is a patient who had no recovery of hand function. This is his damaged cortex, and left damaged cortex, and this is, you see no response in the right finger, in the right 1DI, and no response in the left 1DI, as you'd expect. But when his right intact cortex was stimulated, in the left unaffected side, you've got the normal response to TMS, but you also got one in his affected first dorsal interosseous. However, even though that was present, it clearly wasn't enough to give function to him. He didn't have any hand function. He had quite a tight hand and couldn't open it at all. Hadn't got any dexterity at all. Looking across the group, we split the patients into those who had been mildly affected and those severely affected. And our criteria was if they could actually do this peg transfer task, so that they could move the pegs from this set of holes to this set of holes, they were called mildly affected. If they couldn't do the peg test, they were called severely affected. And looking at the mildly affected group, we didn't get any responses from the healthy cortex into their affected hand. We did get some in the proximal muscles, but you also do get some in normal participants. In the severely affected people, we did get some in the in the fingers, we did find responses ipsilateral to the healthy cortex. So it seems that actually maybe there is some reorganisation to mean that the healthy cortex might be trying to give some drive to those affected muscles, but it's not actually helpful. We found actually these were in about a third of patients from who we had no response at all from the damaged hemisphere. Okay. Now, since that's quite a long time ago, since then there have been further TMS studies and brain imaging studies, and as a rule they've shown that less corticospinal damage, there are more normal patterns of cortical activation in brain imaging, and there are more normal EMG responses to TMS of the damaged hemisphere. And those with greater corticospinal damage are more likely to show activation of additional motor areas in both the damaged side and the intact hemisphere, and there's a greater frequency of EMG responses to TMS in the intact hemisphere. This is just an illustration. This is Nick Ward's work at UCL, and this is one person who recovered only moderate recovery of left-hand grip. He was asking people to use a dynamometer in the scanner, and you can see here the right supplementary motor area, and the bottom graph the ipsilateral primary motor cortex, so the motor cortex on the undamaged hemisphere, and this shows on this axis the kind of amount of activation or the size of the effect in this patient compared to normal controls. So this patient was showing more activation in these two areas than you would normally expect in a healthy person. So since this work, there's been some new work looking at predicting recovery using neuroscience, using TMS and using imagery. And Kathy Stanier came to London fairly recently. I don't know if any of you went to hear her speak. She's from New Zealand, she's developed a model to predict recovery. So if you have somebody, like Mrs. G here, who's retired, lives alone, she likes to be busy, she likes cooking, gardening, doing the crossword. She has a left hemisphere stroke, and at 3 days post-stroke, she's unable to use her arm and hand. She wants to know if she's going to get better. Actually, until now, mostly, I suppose, therapists will look to see if there's any activation, and they'll be able to say, well, yes, there's some activation, it's likely you're going to get a bit better, but not be very clear about how much recovery people are going to get. So Kathy's come up with a model and tested it for predicting recovery. And the model starts with using what she calls a SAFE score. And SAFE stands for shoulder abduction and finger extension. And it's used in the MRC muscle grading that I was telling you about before. So if someone has shoulder abduction and finger extension MRC scores that add up to 8 or more, which is quite strong. Remember that 5 is the most you can get, and 3 is holding against gravity. It's pretty clear you've got those movements. Then you're actually forecast to make a complete recovery. If you have a score of less than 8, which you might be able to see some movement, then the person can be tested with TMS to see if motor evoked potentials are present, and if they are, then they're likely to go ahead and make a notable recovery. I'll come on to what notable might mean in a minute. If the MEP is absent, then they could be scanned using MRI to look at the asymmetry in the posterior internal capsule between sides. And there is a kind of cut-off. I think the difference between limited and no recovery prediction is that these people have an asymmetry of less than 15%. Okay, so she is now using this model in her clinical practice. But beforehand, they tested if it worked using this test. This is a test called the Action Research Arm Test, and it's a rated performance measure, and the assessor has to rate how well people do things like grasp these blocks and put them on that shelf, or grasp using a pinch grip or a more precision grip, tiny marbles and ball bearings. But there's also a section that looks at gross movement. Can someone put their hand behind the head? Can they take their hand to their mouth? Okay, so she was looking at recovery using this measure and against the kind of prediction at 72 hours after stroke, and seeing how well it worked out. And it worked out very well, actually. So these people here were deemed as not likely to recover, and clearly they didn't really recover very much. In fact, they probably could only attempt the gross motor section. They probably weren't able to pick up a block and put it on a shelf. And then there was a group who made limited recovery, and a group who bunched together to make the notable recovery, and then a group at the top who, as a rule, was able to do quite well to start with. As I said, this is the safe score ones of more than 8, and they're much more likely to make a complete recovery. Okay. So she's come up with a kind of recipe, if you like, what kind of rehabilitation people should get according to their predicted outcome. And she says that those who are forecast to make a complete recovery actually still do need to have a rehabilitation program. And she's got a book that people can do on their own, so exercises and activities they can do on their own and practice on their own, which helps them to achieve that full recovery. And she found that actually earlier, before they gave the book, I think that about 60% recovered with no therapy. Once they'd introduced this program for people to do on their own, 90% recovered with the home program. Then there's this notable group, the ones who are going to do pretty well. She's suggesting they have therapy input to promote the function and minimise compensation. So you don't want them, while they're kind of recovering, to learn to do things in new ways or to learn not to use the affected hand. You want them to incorporate it in everyday life and improve that. And then this group here, the limited group, she says they need therapy input to promote movement and strength, and incorporate what they can into activities of daily living. But it's quite likely they'll have to make some compensations in order to be independent. And then for the group that are forecast not to recover, then measures must be taken to prevent them from developing pain and contractures. She's very careful to say, when I heard her speak, that actually everybody, this is only at 3 days this forecast is done, everybody should be monitored, so there might be a chance that people can move groups, although obviously they're a minority. So Mrs. G had a safe score of less than 8, but she had an MEP to the TMS, and they were able to tell her that she was likely to do quite well and with a retraining program, and organise that. So now I wanted to talk a bit about how neuroscience is influencing rehabilitation, motor rehabilitation, and this work is, I don't know if any of you've seen it, this is work by Ranulph Nudo, who's looked at the effects of retraining, dexterity training in monkeys who are given little model strokes in their motor cortex. So this is a map of the motor cortex, a little bit of motor cortex in the animal before the infarct was made, or the lesion was made, and with kind of microstimulation techniques, they've mapped out the cortex according to what each little area represents. So the red in this map represents the digit movements, the green represents wrist, forearm movements, the blue, elbow, shoulder, more proximal movements. Then in the same animal they made a little lesion in an area that was primarily red for the digit here, and in this instance they let the animal recover before remapping. So here's the lesion, black, and you can see that there's a lot of green in this and not very much red. And this animal, when behaviourally, what they were doing was kind of scooping the food up. So they found a new way of getting the food, really. This is an example of an animal who's had the same procedure done, mapping, lesion, and then was given lots of training, which forced the animal to try and make pincer movements to get food out of the food wells, really. And when that animal was remapped, they found that there was a lot more red appeared in areas where there hadn't been red before. So there was some reorganisation of the cortex and the representations of the cortex that was going on that might explain the recovery. These animals were having about 300 repetitions a day, daily training over 2 or 3 weeks, and they were very small lesions. Further work has shown that actually the skill learning and the changes in these representations happens with skill learning. It doesn't happen if you just ask the animal to repeat easy movements. They have to be challenged. So you might think that, well, that's what physiotherapists, occupational therapists do. They try and retrain movement. But for quite a long time historically, people in therapy were much more interested in how to prevent people becoming having increased tone, prevent contractures, and I remember being told not to do things with people because, you might increase their tone. So although it sounds crazy to say that actually this is probably, you think that that therapists were training movement for a long time, the emphasis has changed. And now there have been some studies of task-specific training, but quite small ones, for the arm. And in the national guidelines, it says patients who have some arm movement should be given every opportunity to practice activities within their capacity. I would argue this is a little bit wrong because you want them to practice actually a little bit outside their capacity. But I don't think, maybe I'm nitpicking for their statements. Anyway, there is evidence for task-specific training for the lower limb, for walking, for sit to stand, but a Cochrane review showed that actually the evidence wasn't there for upper limb at the moment, because the studies haven't been big enough, they haven't been high quality enough. So I with some collaborators, we got some money from the Stroke Association to do a feasibility trial of a home-based task-specific training. We focused on reach to grasp training with people who had gone home from hospital, with a view to seeing if we could do it, and then we'll go on to do a bigger trial, hopefully. So we have, in our trial, we have wide inclusion criteria. We didn't know about Kathy Samir's work, although I could have suggested that maybe people with a lot of corticospinal damage might not recover their hand movement. There might be still some benefit in recovering arm movement too. So we wanted to have see who this treatment might benefit. So we had wide inclusion criteria. We wanted people who were able to lift their hand off the knee, up to people who were just quite clumsy still. So we had a wide window, and we also took people up to a year after stroke. We randomly allocated people to usual care, which could vary quite considerably. Once people have come out of hospital and had the immediate community rehabilitation service like early supported discharge, there's a huge variation in what people get. And so some people were getting therapy, some people were being offered outpatient therapy, some people were having community therapists go in, some people weren't getting anything at all when they joined the study. And our group of people were going to be given 14 visits over 6 weeks from a research physiotherapist, and they were also encouraged to practice in the absence of a therapist. And we asked them to practice for up to an hour a day, which we thought was quite a lot. And our aim was to get as many repetitions as we could of challenging exercises. So we aimed for between 1 and 300 repetitions per therapist visit. So this is just this description of the sample. So we got 48 patients for our feasibility study, and because most of them chose to join us after they'd had the most intensive bit of their therapy, they didn't want extra people going into their house when they were already having lots of attention for this, that and the other, and they were just getting used to living at home. The median time for entry to the study was 18 weeks, which is about here on Kathy Stinier's data. So quite late, really, on the recovery curves. And this is a distribution of their scores on the Action Research Arm Test, which has been categorised. So this group here, 0 to 3, there would have been in this group here, Kathy forecast no recovery for. This group would have been in this band here, and this group in the notable recovery. So generally you have quite a moderate to severely affected sample. This is a feasibility study. Our aim was not to see if one treatment was better than the other, or it was to see if the trial could be done, but everyone likes to see the results. So these box plots just show how wide the variation is, and I've explained why that is. We're heartened because the people in the Reach to Grass group, their median scores did improve with the treatment, and it was sustained afterwards. So this is 3 months and this is 6 months. The median scores stayed the same in the usual care group. However, they weren't completely balanced to start with. You can see the median scores is lower in this group than it was in the treatment group. We also asked people who had the intervention what they could do at the end of it they couldn't when they joined the trial, and got some quite nice anecdotes of the types of things, small things, that made a difference to people. So, for example, I could scratch my right arm, turn lights on and off, and steady a plate to eat. I can put the brake on my wheelchair and grip clothing when dressing. I can wrap presents, taking sellotape off the reel. So small things. And we're actually at the moment trying to put together an application alongside some collaborators to take this to a bigger trial. But what else do people do? So there are trials ongoing at present looking at the benefits, or if rehabilitation using robotics could be effective. There's a big trial working from Newcastle looking at that. And the beauty of robots, of course, is you get lots and lots of repetitions, and you can have adaptive exercises. There's a study in Cornwall that's just finished looking at the use of use of the Wii. And this monster here is coming out of the Bristol Robotics Lab. So this is an exoskeleton, which obviously needs work, but the beauty of an exoskeleton is you could, if it was nice and slimline and usable, it could be used all over the place for doing all sorts of things. So there's a lot of work that's going on, and hopefully we will be able to improve the lot of people with poor upper limb function after stroke. But I suppose what I wanted to get across to you today is that what we've learned from neurophysiology and from neuroscience has helped us in that direction. Thank you very much for listening.
No idea. Sorry about the echo. Quite interesting. Any questions?
Two questions actually. First is I was interested in the ipsilateral contribution to the corticospinal tract and the data that you showed us, and I wonder what is the possible mechanisms for that. So I guess for the involvement of the cortex is an important factor, because if you have a stroke that extends to the subcortical regions, you'll have a callosal involvement, so you actually have a double disconnection, corticospinal tract, but also the other side. So when you don't have the callosal, because it inhibits the other side, so you may have a release. So perhaps that could be, that's the first mechanism that came to my mind to explain your data that actually severe patient will show that it's lateral contribution.
Mm-hmm.
So that's my first question.
Possibly. I know there's certainly work using TDCS, isn't there? That these little things you go around your head instead of having a big coil that can be used to suppress or excite cortices, and the scientists that have been doing that have shown changes in the excitability from using that, but I don't know that they've actually looked at the same group of patients to see if there's differences. And I'm not well enough up on the information to know if they split it down to people who've recovered well or not recovered well. There's some work that was presented at Rogers conference from Stuart Baker in Newcastle, who's suggesting that he thinks the reticulospinal system can be used to help. But I can't answer your question, I'm afraid. But there were just some ideas that were going around. Yeah.
And I've heard two things about possible treatment. One was the cortical stimulation, direct cortical stimulations. There was a trial, I think, in Germany with high hopes that I think phase 3 didn't really show any improvement. The second is the use of TMS as a treatment tool.
I think that the TDS ones, I think that they haven't been big enough for looking at kind of measures I was showing with the Action Research Arm test. I was involved in a application with somebody who wanted to do a bigger study, and her argument was that actually, although there are trials going on, they're still at this feasibility study kind of size rather than large enough samples. Yeah, quite hard work getting all those people. And I know John Rothwell's done some work with TMS, but I can't remember the result. But you could look up his papers.
I have a question about age. Are you more likely to recover from the stroke the younger you are, or is it kind of independent of the severity?
Oh, it does depend on the severity, but I think within that, when they're broken down, I think people with less severe strokes, if they're younger, they do better. But if you look at very severe ones, then not necessarily.
With the study you showed, though, with the graph and the 4 different stages, was that within a narrow age group, or was it?
I can't remember. Sorry. Yeah. Often these studies are artificially younger than the normal stroke population. So I think people are in their 90s don't often get into trials, and especially that involve things like TMS and going down to a lab somewhere. I think more naturally in the samples I've had, it's unusual to have people in their 90s, for example. It's very and you get a kind of skew, really, so you more like to get younger people into those studies.
It says 18 years old and older. It doesn't specify.
18 and older.
18.
18 and older.
Oh, okay.
any data on the, like a follow-up on those people who had like no recovery? Because I wonder if like by telling people maybe that could hinder actually their recovery because they might then get less motivated to actually exercise, and if they were told.
I think that is a good question. I think that at the moment, especially in the UK, therapists are particularly not wanting to tell people they're not going to get better. They'd rather kind of give them a chance and wait and see. But and I don't really know what's happening with. This model has been used in New Zealand, and they're gathering more and more data on it to kind of confirm their model, if you like. But and I think that trying to get money to see what happens in the long term, so 2 years afterwards. But certainly, it's very difficult to tell people that you're not going to get better, isn't it? And yeah, some people don't want to hear that. Yeah, I don't think therapists are ready to say it very often.
I suppose if you've got MRI evidence and some sort of electrical evidence that shows you're not going to recover and you're certain of that, it can be quite convincing.
Mm. Yeah.
I think just subjectively, though, both Amarita and Patricia Neal, of course, would have been written off.
Yes.
And yet both of them had almost full recovery.
Yeah.
Patricia Neal nearly came out of Oscar, and of course Amarita was back lecturing within a year. So both of those would have been completely written off. They had zero.
And actually, you know, I think that
it's subjective.
yeah, that measure, the action research arm test measure, is a measure of using the hand and lifting up your arm pretty high. And actually, I think the little quotes that I showed show that actually, even if you don't get your hand back, getting a bit of arm movement back can be helpful. You know, you can wash under your arm, you can get dressed more easily. Whether that's acceptable for justifying lots of resources, I don't know, but you know, to people who are experiencing those changes, they're important.
So in terms of upper limb evidence, would you not include constraining the good arm as part, because there's some evidence that can help improve the weak arm if you've got some power there.
Yes, and in fact, you know, as kind of big trials go, it's the strongest evidence for actually being effective. So this is a treatment where you put a mitt onto the unaffected hand, and you do lots and lots of practice with using the affected hand. But to be eligible for that treatment, you have to have a little bit of finger extension, you have to have a little bit of wrist extension. So you're not in those very limited groups I showed. You were at the higher end of the scale, and yes, people are using that, and they are trying to apply it to patients in the UK. It's not a very popular treatment.
And what's the difference? Are you using a different group of patients in your pilot study?
Yes, although we had a big wide open window, the people who came in were actually more severely affected than you know, there aren't many in our sample who would have been eligible for brain-induced therapy. And that's I think that's whether what we lack is something for people with more severe stroke.
Patients with the good recovery, how long do the benefits of the TMS take after the start of the TMS stimulation? And does it is the good recovery is also for cognitive functions, or for example in the left stroke for aphasia?
So when TMS is used as a treatment, how long does it last?
No, when you stop the TMS, the benefit, does it take for months or for weeks after the stop?
So it lasts.
How long does it last when it's delivered as a treatment? Asking.
Yeah.
I don't know, but I think people have, a few studies I've read about, there's a kind of decay after a few days, but I'm not really sure of that. So,
Actually, in aphasia and stroke, there's some quite a few anecdotes that show that people that had a left hemisphere stroke and aphasia, they actually recover, and then when they have another stroke on the right side, they actually lose completely language. So there's an evidence that actually contralateral side is taking over some of the functions. And I wonder whether there is something similar for stroke and motor functions as well.
I don't know about for the upper limb, but there's the work by Sheen and Handy with the swallowing, and swallowing being more kind of axial and central. There were representations in both cortices for that musculature, and what he's done is had a look at the representation and then tried to simulate to improve the representation in the cortex where it has bigger representation to try and bring back swallowing. So I imagine that scenario you suggested there could happen. So you could get your swallow back after one stroke, and then you could lose it again with a stroke on the other side. But that's just speculation, but I expect it's true. Yes, it sounds a similar story.
Any more questions? Yeah. Okay. Thank you very much.
Thank you very much for listening.
There are some sandwiches left, so help yourself. And then see you next month for the next talk, which is
4th of July. 4th of July.